Hello everyone. Today we are going to discuss another set of one-liners in pediatrics. To start with, which one of the following is not true about ALAGILE syndrome? We know about ALAGILE syndrome, but among these four, which one is not true? Is it due to mutation in JAG1 gene? Is it true or false? Due to mutation in NOTCH2 gene. It is associated with posterior embryo traction that is commonly seen in eye. It is in case of ALAGILE syndrome. Is it true or false? And the fourth one is autosomal recessive inheritance. Among these four, which one is not true? So answer would be the last one, that is autosomal recessive inheritance. Point to remember is the ALAGILE syndrome can occur both because of JAG1 gene and mutation in NOTCH2 gene. That is the confusing point which they may give you in exam. So not true is actually it is autosomal dominant recessive due to autosomal dominant mutation inheritance mutation in either JAG1 or NOTCH2 gene. Clinically it is characterized by the triangular faces. You can get deep set eyes. You can get prominent forehead, pointed chin. This is a characteristic triangular face. What we will get in your ALAGILE syndrome. What extra we can get? We can get peripheral pulmonary stenosis, we can get cholestatic jaundice, and we can get posterior embryo traction. And along with that, one classical butterfly vertebra, that also we can get in ALAGILE syndrome. So these are the classical clinical picture, and the new thing is you can get ALAGILE syndrome because of mutation in either JAG1 gene or NOTCH2 gene. Both are responsible for your ALAGILE syndrome. Next, glycogen storage disease type 0 is due to deficiency of what? We know about 1, 2, 3, 4 all these, but in type 0, what is the deficiency? Which enzyme is defect in type 0 form of glycogen storage disease? The answer is glycogen synthase enzyme. This we have to remember. Glycogen synthase enzyme, when it is absent, the glycogen storage disease, that is classified as type 0. Some important one-liners in GST, glycogen storage disease. Which form is associated with hemolytic anemia? It is Darby. Second wind phenomenon is associated with which form of glycogen storage disorder? That is Macarals. Cirrhosis and early death we can get in Anderson type. Cardiomegaly we can get in Pompey's variety. Increased uric acid level, that will get in Burn-Kirkett disease. Cramps and myoglobinuria we will get in Macarals disease. So this we have already discussed previously, but for today the new thing is glycogen synthase enzyme, the deficiency can cause type 0 form of glycogen storage disease. Next, which among the following is not coming under Hutchinson triad? Hutchinson triad, what we get in congenital syphilis, which one is not there? Hutchinson teeth, mulberry molar, interstitial keratitis, or 8th nerve deafness. The answer would be, it is the mulberry molars. All these three, Hutchinson teeth, interstitial keratitis, and 8th nerve deafness, all these three we can get under that Hutchinson triad. So features of these are the Hutchinson triad, that is for your late congenital syphilis. As you know, there are two manifestations, two types. One is early, one is late congenital syphilis manifestation. Early, that is within 2 years, and late is manifestation will get after 2 years. Hutchinson teeth, what do we mean by Hutchinson teeth? The peg-shaped notched incisor, this is called Hutchinson teeth. What are the other findings in late congenital syphilis? We'll get Cloton joint. What do we mean by Cloton joint? This is the painless bilateral swelling of the knee joint. That is known as your Cloton joint. Saddle notch, Olympian brow, this will get in early syphilis. What do we mean by early syphilis? The manifestation would be within the first 2 years of life, either during the neonatal period or within the first 2 years of life. The classical clinical picture is your snuffles or rhinitis. You can get rash, you can get hepatosplenomegaly, and you can get pseudo paralysis. So Hutchinson triad, what is not there is your mulberry molars. Next, Luton-Backer syndrome is Which among the two combination is known as Lutenbacher syndrome? Is it congenital ASD plus congenital MS, or congenital ASD plus acquired MS, or congenital ASD plus congenital MR, or congenital ASD plus acquired MR? The answer is congenital ASD plus acquired MS. Next, what among the following neonatal seizure is having best prognosis? Is it myoclonic seizure? It is subtle seizure? Is it focal seizure or focal tonic? The answer is focal clonic. Some points about your neonatal seizure. Which one is the most common type? It is subtle seizure. Which one is the most common cause of neonatal seizure? The answer is hypoxia. Which one is having best prognosis? That is focal clonic. Which one is having worst prognosis? That is myoclonic seizure. We can get some questions related to your neonatal seizure. Most common type is subtle. Most common cause is hypoxia. Best prognosis, it is not subtle, it is focal clonic. Worst prognosis is your myoclonic. Then next one, milestone shown in the picture achieved by what age? First we have to think, what is this? Is it crawling or is it creeping? That is the most confusing part. Then if you know it's crawling or creeping, then it's very easy to know. Then this is your creeping. When the chest is touching the ground, then that is your crawling. When chest is with some distance above the ground, then it is called creeping. Crawling, your CRA, A comes first, that is at 9 months. Creeping at 10 months. Next, which investigation would you like to do in a mother whose neonate is having ECG shown in the picture? Neonate is having the ECG as shown in the picture. What will you get in this picture? This is a complete heart block. There is no relation with your P and QRS complex. A complete heart block. Then what is the suspected disease in the mother? That is SLE. Then if you are suspecting SLE, then which investigation we want to do in the mother? It is the serum anti-Rho and anti-La. Maternal SLE can cause complete heart block in a newborn. Serum zinc level less than what is suggestive of acrodermatitis enteropathica? Is it less than 50 or less than 100 microgram or 150 or 200? What should be the zinc level to stamp this as acrodermatitis enteropathica? The answer is less than 50. Some points about acrodermatitis enteropathica, it is due to genetic defect in the intestinal zinc specific transport gene, that is SLC39A4. This is the defect in this intestinal zinc transport that will lead to your acrodermatitis enteropathica. Signs and symptoms after weaning from breastfeeding. Your lymphocyte function and free radical scavenger get impaired. Dose for your acrodermatitis enteropathica, dose of zinc is 3 mg per kg per day. 3 mg per kg per day is the dose of zinc in acrodermatitis enteropathica. In acquired zinc deficiency, your dose of zinc is 0.5 to 1 mg per kg per day. Another one thing, acrodermatitis enteropathica is the one condition where lifelong zinc is to be given. Another condition is your Wilson disease, but in Wilson, your zinc is the second option, second treatment option. First is your penicillin, but in acrodermatitis enteropathica, first treatment is your zinc, which we need to give lifelong. Next, identify the X-ray. What we are getting in this X-ray? We are getting coiling of the catheter, and what else? What else we are getting? We can, if you mark, then there is no gastric shadow, fundy gas, no fundy gas. So answer would be esophageal atresia. Next, mother is taking low dose heparin throughout pregnancy because of a past history of deep vein thrombosis. Which of the following anomaly is expected in the baby? Mother is taking heparin. So what anomaly you are expecting in the newborn baby? Is it hypoplastic nasal clone? Are you expecting cutis laxa? Are you expecting Epstein anomaly, or a heparin is a safe molecule? Yes, molecule we are not expecting anything. The answer is heparin is a safe molecule. There you may not get any congenital malformation in the newborn baby, but we can get teratogenic effect of if mother is taking warfarin. which can cause hypoplasia of the nasal cartilage. Your cutaneous laxus syndrome, that is commonly associated with your penicillamine. This is the classical. We can get some MCQ. We may get anytime. So you have to remember some antenatal drugs which are having some teratogenic effect. Classically, you can get penicillamine that can cause cutaneous laxus syndrome. If the mother is taking lithium, then we can get Epstein anomaly and macrosomia in the newborn baby. If mother is exposed to hyperthermia in the antenatal period, then we can get spina bifida in the newborn baby. Another is mother is taking heavy dose vitamin D, then we can get supravalvular aortic stenosis in the newborn baby. So we have to remember some antenatal molecules which are teratogenic. Thank you. Please like and share this video and subscribe to my channel. Thank you.